Welcome. Today we're diving into a fascinating and sometimes challenging area of eye health: metabolic cataracts. These aren't your typical age-related cataracts. Instead, they develop as a consequence of underlying metabolic disorders within the body. Join us as we explore what causes them, how they affect the eye, and what can be done to manage them. Metabolic cataracts are primarily caused by systemic metabolic diseases that disrupt the normal biochemical processes of the lens. Galactosemia, a rare genetic disorder where the body can't properly process galactose, is a prime example. The accumulation of galactidil in the lens leads to cataract formation. Hypocalcemia, or low calcium levels in the blood, can also induce cataracts by disrupting the lens's ionic balance. Diabetes, while often associated with typical age-related cataracts, can also lead to more rapid and severe cataract development through hyperglycemic damage to the lens proteins. Other, rarer metabolic conditions like hypoparathyroidism and Wilson's disease can also, in some instances, be linked to cataract formation. The lens of the eye relies on a delicate balance of electrolytes, proteins, and glucose metabolism to maintain its clarity. In metabolic disorders, this balance is disrupted. For example, in galactosemia, the accumulation of galactidil, a sugar alcohol, increases the osmotic pressure within the lens. This draws water into the lens fibers, causing swelling and opacification. In hypocalcemia, the low calcium levels affect the calcium-dependent enzymes within the lens and disrupt membrane permeability, leading to protein aggregation and lens clouding. In diabetes, high glucose levels lead to the formation of advanced glycation end products, or AGEs, which damage lens proteins and promote cataract formation. Metabolic cataracts are relatively rare compared to age-related cataracts. Galactosemia is a rare genetic disorder, with an incidence rate varying depending on the population. Screening programs have helped to identify affected individuals early. Hypocalcemia-related cataracts are also relatively uncommon and are often associated with underlying medical conditions like hypoparathyroidism or vitamin D deficiency. The prevalence of diabetes-related cataracts is more significant due to the increasing global prevalence of diabetes, although these can often appear as age-related cataracts but develop earlier and faster. The symptoms of metabolic cataracts are similar to those of other types of cataracts. Patients may experience blurred vision, glare, halo surround lights, double vision, and difficulty seeing at night. However, metabolic cataracts can sometimes develop more rapidly, particularly in cases of galactosemia, where infants may present with cataracts shortly after birth. The rate of progression and the specific symptoms can vary depending on the underlying metabolic condition and the severity of the metabolic imbalance. Diagnosis of metabolic cataracts begins with a comprehensive eye examination by an ophthalmologist. This includes assessing visual acuity, performing a slit lamp examination to visualize the lens, and possibly dilating the pupils to get a better view of the entire lens. Identifying the underlying metabolic disorder is crucial. This often involves blood tests to measure glucose levels, calcium levels, galactose levels, and other relevant metabolic markers. Genetic testing may be necessary to confirm specific genetic disorders like galactosemia. A thorough medical history is also essential to identify any other underlying conditions that could contribute to cataract development. While there aren't strict classifications of metabolic cataracts based on the underlying metabolic disorder, the appearance and location of the cataract within the lens can sometimes provide clues about the underlying cause. For example, galactosemic cataracts in infants often appear as oil droplet opacities in the lens. Cataracts due to hypocalcemia are often characterized by iridescent, snowflake-like opacities. However, these are not always definitive and further investigation is always required to confirm the diagnosis. The primary treatment for metabolic cataracts is surgical removal of the cataract and replacement with an artificial lens, or intraocular lens IO. Phocoemulsification, a common surgical technique, is typically used to break up and remove the clouded lens. However, addressing the underlying metabolic disorder is equally important. This may involve dietary changes to reduce galactose intake in galactosemia, calcium supplementation in hypocalcemia, and strict blood sugar control in diabetes. Optimal metabolic control can help prevent or slow the progression of cataracts in the fellow eye or reduce the risk of recurrence after surgery. Prevention of metabolic cataracts focuses on early detection and management of the underlying metabolic disorders. Newborn screening for galactosemia is crucial for early intervention. Maintaining adequate calcium levels through proper diet and supplementation can help prevent hypocalcemia-related cataracts. Strict blood sugar control through diet, exercise, and medication is essential for preventing or slowing the progression of diabetic cataracts. Regular eye examinations are also important for early detection of cataract development, regardless of the cause. The prognosis for patients with metabolic cataracts is generally good with appropriate management. cataract surgery is typically successful in restoring vision. However, the long-term visual outcome depends on the control of the underlying metabolic disorder and the presence of any other ocular or systemic complications. Recent research has focused on developing more targeted therapies to prevent cataract formation in metabolic disorders, such as aldose reductase inhibitors to reduce galactidal accumulation in galactosemia. Advances in intraocular lens technology are also improving visual outcomes after cataract surgery, with newer lenses offering better vision correction and reduced glare. Research continues to explore the complex interactions between metabolic pathways and lens health to develop even more effective prevention and treatment strategies in the future.